Hello guys, and welcome to this very important video to talk about one of the most important questions during our entire dental careers, which is how to perform a very nice occlusal adjustment following the principles of occlusion, okay? So we need to offer those principles of occlusion to our patients. And we know that sometimes the occlusal adjustment is not enough. Sometimes we need to offer different treatments to change the occlusion of the patient, okay? We have crossed bite, for example, so there are other situations, but at least you should be able to perform a very nice occlusal adjustment at the end of a rehabilitation or after performing a restoration, for example. The first key point of today is that we need to identify the missing principles of occlusion. So first we're going to check the centric occlusion, okay, or maximal intercuspation. What are the principles that we need to check? And basically those are the principles. I'm going to start with the axial loading. So actually we need to check if the occlusal forces are directed parallel to the long axis of the teeth, especially of the posterior teeth. That's axial loading, and we need to check that during the occlusal adjustment. Okay, you can check if the forces are parallel to the long axis of the posterior teeth, especially. So we need to check that. That leads us to the next very important characteristic, which is the posterior stability. Okay, so basically we need to have balanced contacts on both sides, of course, right? So of course you're going to check that on the articulating paper, first in centric occlusion, okay? And three types of contacts are acceptable, or at least the three main types of contacts, and it's the cusp to fossa, cusp to ridge, and then the tripodized contact, in which we have the surface of the cusp touching in three different places the antagonist tooth, but without touching the fossa of the antagonist tooth. And we know that this is sometimes a little bit difficult to achieve, but we should give priority to the cusp to fossa over the cusp to ridge contact if possible, okay? Because the cusp to ridge is already proven to, if there's too much cusp to ridge contact, it will lead to more food packing, for example. So this is a possibility. That's why usually we have more cusp to fossa contact. So those are characteristics that we are going to use to follow our occlusal adjustment, for example, with the articulating paper. So you guys will pay attention to those factors. Then we also have the two very important occlusal plane curves, and that's the curve of Spee and the curve of Wilson, okay? So the curve of Spee is the ascending curve from the canine, from the cusp of the canine, connecting with the buccal cusps of premolars and then of molars, so that's an ascending curve, and of course that leads to a very nice occlusion, okay? So the forces are more balanced, and that's a curve already described. Then there is the curve of Wilson, which is the posterior occlusion curve. There is a concavity that we need to respect as well, and both curves need to be checked during your occlusal adjustment, okay? So do a very nice clinical intraoral examination and check the occlusion not only with the articulating paper, but look for those factors during your examination. Now that you checked the centric occlusion, the next step is of course to check the excursive movements, all right? So of course we need to look for other principles of occlusion here, and I'm talking about the canine guidance and the absence of contacts on the non-working side for lateral excursion. So the patient is biting and the patient moves the chin to the right side, sliding the teeth. And then that's canine guidance. Only the canine is touching. The lateral cannot touch, otherwise it's interference. We can see this with the articulating paper, and then only the canine will have a line, confirming a good occlusion. So those are ideal features. Of course, instead of the canine guidance, we may have group function. So we may have the contacts of premolars, even molars, together with the canine, so along with the canine, but then we should not have contacts on the non-working side. So for protrusion, we need to have the incisive guidance. So basically the incisive guidance will be performed between the antagonist incisors, and it will disocclude the posterior teeth. Okay, so that's also very important. If the posterior teeth are touching, we consider this as an interference. Now let's go for the second key point, which is to detect the incorrect restorations or tooth shapes and positions, okay? Most common factors that always happen, and we need to recognize those factors, to detect those factors, are basically the presence of premature contacts, okay? So we need to detect those contacts. We can use, for example, the articulating paper, and then big circles, and especially the big circles with a hole in the middle, they are telling us that we have a very strong contact. So those are excessive occlusal forces, and then we need to adjust those. However, the presence of premature contacts may be happening due to factors such as the presence of over-erupted teeth due to the absence of antagonist, and of course we need to plan a treatment for that as well, okay? Also, cases of tooth wear, we need to plan a rehabilitation for this tooth wear because it will affect our occlusion. And factors like tooth wear and bone loss may lead to something very important, which is an incorrect vertical dimension of occlusion, okay? We need to recover this vertical dimension. So sometimes we need to increase the vertical dimension of occlusion, and of course this will require more than a simple occlusal adjustment with articulating paper, for example. And sometimes the patient has cross-bite, and sometimes we are dealing with cases of class 2 or class 3 according to the angle classification, and then we need to go for ortho, for example, right? So we need to correct this occlusion, and we cannot do that only with a simple occlusal adjustment, okay? So pay attention to these factors as well, because you are going to offer the best treatments for your patient in your treatment plan to fix the occlusion of your patient, and then at the end of your rehabilitation, then you are going to proceed with a very nice occlusal adjustment as well. And then after your treatment, so you did restorations, for example, you did all your treatments, and the third key point, which is to perform the adequate occlusal adjustment, okay? How to do that? Well, you can use digital devices to detect the occlusal contacts, or you can just use the articulating paper, you know, old school, just like, you know, the majority of dentists. But then we need to use this properly. So first we need to assess centric occlusion, okay? Don't ask for the patient to bite, tack, and grind and try to see all the curves at the same time. Instead, first you check the centric occlusion and then the excursive movements, okay? So check the centric occlusion, see the axial loading, check with the articulating paper if the contacts are balanced between both sides. So if we have a posterior stable occlusion, you can always check this reference. This is a very nice article talking about that as well. And then we have a very nice tip for you to do that, which is use the red color for the centric occlusion and then black and blue color of the articulating paper for excursion. Why? Because the black and blue will mark over the red color, okay? So you'll be able to see what is centric occlusion and what are the lines that are telling you about the excursion movements. Then what you need to do? You need to detect the premature contacts in centric occlusion, of course, right? So we may have a circle, we may have a big circle, and we may have a big circle with a hole in the middle, and that's the one that you need to adjust first. Then we need to detect interferences in excursion. How? Following the principles of occlusion. So you are going to pay attention if there is canine guidance, if there are no contacts on the non-working side, if we have the incisive guidance in protrusion, so no posterior interferences, and then you will be able to use your finishing burrs and your polishing kit, especially on the restorations that you just did, to ensure comfort and lower risks of fractures for your patient. See you guys on next videos.